So thank you so much for joining us today. We have the pleasure of welcoming Dr. Juan Celedón. He's a distinguished physician scientist and international leader in pulmonary medicine. He's currently serving as professor of pediatrics, medicine, epidemiology, and human genetics at the University of Pittsburgh. He's a former president of the American Thoracic Society and has made seminal contributions to the understanding of the genetic, environmental, and social determinants of asthma and chronic lung disease, with a particular focus on health disparities. Dr. Celedón has authored over 500 peer-reviewed publications, and he's had a profound impact on the field. His work spans genetic epidemiology, multi-omics approaches, and population-based studies, shaping current paradigms in asthma research and precision medicine. He's widely recognized for his leadership, mentorship, and commitment to advancing equity in respiratory health, and he has received numerous national and international honors, including the American Thoracic Society's highest distinctions. So please join me in welcoming him, and we're just looking forward to hearing your presentation today.
Thank you, Jose Luis, for your kind introduction and your invitation. Thanks to Dr. Kaminsky and the faculty for your hospitality. So what I'm going to talk to you about today is asthma endotypes in minorities. I don't have any disclosures. So asthma, as you know, affects about 300 million people globally. In the US, 25 million people, including 90 million adults, have asthma. It is also the most common chronic respiratory disease in children worldwide. But about 65 to 70% of cases of asthma start in childhood, which explains why, which is a question that I'm asked often, an adult pulmonologist like me that's also researching kids. If you want to prevent the disease, you have to start almost in utero. As you know, asthma is characterized by airway inflammation, remodeling, and hyperreactivity to non-specific stimuli, and airflow obstruction that is often, but not always, reversible. But asthma is not an equal opportunity disease. These are data for all patients, for children and adults. So compared with non-Hispanic whites in this country, non-Hispanic Blacks, multiracial individuals, American Indians, and Alaska Natives have a higher prevalence of asthma across the lifespan. Now, when you look at this particular graph, it would appear as if Hispanics or Latinos have lower prevalence of asthma than whites. But this is a fallacy introduced by the US Census. According to the US Census, a Hispanic or Latino is any individual who can trace his or her ancestry to lands that were previously under Spanish control. It's very confusing to people, including those in the current administration, but Hispanic is not a race. It denotes a common cultural heritage. In fact, the 6 individuals pictured in this slide would check the box Hispanics in the US Census. They include Rigoberta Menchú, who's a Mayan from Guatemala who won the Nobel Prize for Peace, Alberto Fujimori, whose parents are Japanese, but he's Peruvian and therefore Hispanic. Cesar Chavez, a labor activist who's in the news, not for good reasons right now, who has Native American ancestry. And then you have David Papi Ortiz of my favorite team, the Boston Red Sox, who's Afro-Dominican. And of course, 2 comadres from my hometown, Sofia Vergara of Modern Family and Shakira, whose father is Lebanese. If you put all of these people together in biomedical research, you're going to get biased results. I was first introduced to this concept of heterogeneity at Lincoln Hospital. So after 400 letters of application, I had 7 interviews, and Steven Peterson, who's pictured in this slide, gave me the opportunity to serve my internship at Lincoln. Lincoln is in the South Bronx, the poorest congressional district in this country. It has the highest prevalence of intravenous drug use, children born out of wedlock, and I trained there at the peak of the AIDS epidemic. 25 to 30% of patients I care for had AIDS when there was no treatment. I was also struck by how segregated the place was. I saw 4 white patients in 1 year. I can tell you who they were and what profession, if any, they had. And I was struck by how much asthma and how severe asthma was in Puerto Ricans and African Americans. And I didn't know it then, but that became, trying to understand why, became the crux of my research career. So in fact, once you decompose Hispanics into subgroups, a completely different picture emerges. So these are data for adults in a study called the Study of Latinos, or SOL for short. Puerto Ricans have nearly 5-fold higher prevalence of asthma than Mexicans. This phenomenon is known as the Hispanic paradox. You also see this for morbidity. Compared with other Hispanic subgroups, Puerto Ricans have much higher rates of healthcare utilization, use of steroids, ED visits, and hospitalizations, with other groups like Dominicans and Cubans in between. So in fact, when you look at this with a broader lens, Blacks and Hispanics have 1.5 to 2 times higher prevalence of asthma. Blacks have 3 times higher risk of hospitalizations or emergency department visits for asthma, and 5 times higher mortality, with Black women having even higher risk. Why do these disparities occur? There are factors at the individual level, the one not being modifiable yet, genetics, but everything else in this picture is modifiable. They include things like the indoor environment, diet, obesity, exposure to violence, I'll talk about this tomorrow, stress, access to healthcare. And at the community level, you have some of the same things, and then you add things like outdoor air pollution, housing conditions. And in any patient that you see, many of these factors coexist. The wheel goes round and round. But at a deeper level, 90 to 95% of these disparities occur because of unequal exposure to environmental risk factors that is in turn determined by structural and social determinants of health. Racism, segregation, redlining determine where people live. Depending on the community you live, you're going to have more exposure to outdoor air pollution, violence. There's going to be more discrimination, less access to education, and this finally has an impact at the individual level. When you go back to the Hispanic paradox, this slide is from 11 years ago, and you compare Mexicans and Puerto Ricans, there are differences in ancestry. In general, Mexicans have, on average, 50% Native American ancestry, the ones who migrate here. Puerto Ricans, on the other hand, have 25% on average African ancestry. Unfortunately, African ancestry is not only a marker of genetics, but also of skin color, which is tied to discrimination. But in addition to that, you have other factors. Puerto Ricans have the higher rates of prematurity. Puerto Rican women smoke the heaviest among women in the United States. You have greater decreased bronchodilator response, more on this in a bit, and then greater susceptibility to stress. Whereas Mexicans have less tobacco exposure. Now, there are factors that are common to both groups. These include things like obesity, limited access to healthcare, and low or limited health insurance. Going beyond disparities, the prevalence of asthma went skyrocketed from a period that went probably starting in the 1950s to at least the 1990s in many Western countries. In some, it has plateaued. In some developing countries, it continues to rise. The one thing we can conclude from this slide is that this is not genetics, right? In humans, the rate of mutations is 3 per generation. Something had to change in the environment that alter the expression of susceptibility genes for asthma. And one of the ways that the environment affects biology is epigenetics, which can be broadly defined as changes in gene expression that do not depend on your DNA sequence. If I took a random member of this audience and I took samples of hair, saliva, white blood cells, ran that through a DNA sequencer, I would get the same sort of response. Why is it then that your hair that fulfills a function different from your lungs or your vocal epithelium? Because your epigenome is cell-specific. So while your genome is the same, your epigenome varies. One of the other characteristics of the epigenome is modifiable and is active or poised to be activated. We have been particularly interested in a mechanism that is DNA methylation. Now, years ago, people doing human genetics of atopic dermatitis, a classic Th2 predominant disease, were really focusing on T2 and T1 immune responses. There were tons of GWASs and other studies, and their findings were of limited impact until they found that filaggrin, which has nothing to do with immune responses, but the integrity of the skin barrier, was a pretty strong susceptibility gene for AD. And then people in asthma came up with this hypothesis: couldn't this be happening also in asthma, where the key defect is dysfunction of the airway epithelial barrier? So under this hypothesis, if you have a dysfunctional epithelial barrier, there is penetration of injurious agents, being viruses, pathogens, or allergens, that interact with dendritic cells and precipitate a cascade of immune events that leads to different types of asthma. Knowing this, and also the fact that Avi Spira and others showed that both DNA methylation and gene expression in nasal epithelium are well correlated with those in bronchial epithelium, particularly in non-smokers, we started 13 years ago to collect nasal samples in children and adults with and without asthma for studies of DNA methylation and gene expression. We also know that asthma is a heterogeneous syndrome, including phenotypes that are familiar to you all: obesity-related, atopic versus non-atopic, occupational, etc. And then these phenotypes can be further characterized into molecular mechanisms or endotypes. More on this later. So a few years back with Dr. Eric Forno, who's now in Indiana, we conducted a genome-wide study of DNA methylation and atopy and atopic asthma in children, adolescents, and young adults. And there were 3 cohorts in this analysis. The first one was from Puerto Rico, 483 Puerto Ricans aged 9 to 20 years, with and without atopy, with and without atopic asthma. The second cohort was a much smaller case control study, led by my colleague Ivana Yang in Denver, only 72 kids living in Denver with and without atopic asthma. The third cohort, unlike the other 2, was a birth cohort study. Nasal samples were taken when the participants were 16 years of age. They were all adolescents. And the proportion of participants with asthma was much smaller than in the other 2. To summarize, the 3 cohorts were very different with regard to geographic location, racial or ethnic composition, and study design. On this slide, on the left side, you see a Manhattan plot summarizing the results of the Epigenome-wide Association study of atopic asthma. On the horizontal axis, you see autosomal chromosomes. The red line denotes statistical significance. There were about 8,000 methylation markers or CpGs associated with atopic asthma in this analysis. On the other side, you see a volcano plot showing that most of these markers affected expression in the way you'd expect it. That is, more methylation, less expression, and vice versa. But this was truly remarkable. We were able to replicate 28 of the top 30 signals in Puerto Rico in the other 2 cohorts, both with regard to a direction of the association and statistical significance. But to me, even more interesting than this was the fact that if you look at the estimates of effect, that is the methylation changes, they were very similar between Puerto Ricans and African Americans and much lower in the Dutch participants. This could be explained in 2 different ways. One, the frequency of the SNPs that affect DNA methylation are different, or the intensity of exposure to environmental risk factors for asthma is much greater in Puerto Ricans and African Americans than in the Dutch kids, right? If you try to do the same exercise in genetics, you would never get these results, right? We're talking sample sizes lower than 500 for all studies. Now, as clinicians, you're interested in trying to differentiate or identify patients. So what we did was, using 3 machine learning approaches, we took a panel of 30 CpGs and tried to differentiate, this is cross-sectional data, not longitudinal, the kids with and without atopic asthma. And we found that the accuracy was 88% in the discovery cohort, 82% in the much smaller African-American cohort, and 87% in the Dutch cohort. By comparison, if you use questionnaire data or genetic markers, your accuracy will be in the 60 to 65% realm. So very promising. We also did a pathway analysis, and here you have the usual suspects like Th1, Th2 immune responses, but we also saw signals for gap junction signaling, which would be related to epithelial integrity. And among the top signals, there were signals for adherence, CDH26 and CDHR3, which is also a receptor for rhinovirus. Again, suggesting that there may be something to this airway epithelium hypothesis. Now, let me go back to endotypes. So it's a cartoon from a paper in the New England Journal by Brussel and Koppelman. On the left side, you have T2 high asthma characterized by airway eosinophilia with and without allergy. And now, as you all know, we have a ton of monoclonal antibodies, biologics to treat T2 high asthma. On the right side, you have the poor sister, T2 low asthma. We know it includes T17, T1, perhaps low. We know much less about these endotypes, and we have no specific treatments for them. These were two landmark papers, first by Prescott-Woodruff and Fahey from UCSF. They show that if you characterize gene expression in bronchial epithelium of adults with moderate to severe asthma, you can identify T2 high asthma. And then David Choi from Regeneron in San Francisco did another study where he added markers for T17 immunity. And with that, he could identify T2 high, T17 high, and low endotypes or profiles. Now, in kids, we were very concerned about the fact that people for many years have equated atopic asthma with T2 high asthma. That is, that any patient who had sensitization to one allergen or more had T2 high asthma. And there was a lot of recent epidemiologic data to suggest that this may not be correct. This is important because, as I said, the treatment and the response to treatment is different. So we wanted to test this hypothesis. This was work conducted by Molin Yue, who was a predoctoral fellow, and Cristina Galleto, who's one of our junior faculty in Pittsburgh. And our hypothesis were that nasal epithelial expression of 3T2 and 5T17 signature genes could identify three distinct asthma endotypes in this study in children and young adults. That the T2 high profile, contrary to broad assumptions, would be less common than the T2 low endotypes. And that using a combination of common biomarkers, we could identify the T2 high profile. So these are the results. On the left side, these are heat maps. There were three cohorts in this study. STAR included 156 Puerto Ricans and African Americans, ages 8 to 20 years. The second cohort is EVA-PR, comprising 237 Puerto Ricans, aged 9 to 20 years. And the third cohort, BDKA, comprised white and black kids in Pittsburgh. In each one of these heat maps, what you can see is the T2 high profile is denoted by high expression of the T2 signature genes. It's on the left side, the left column. And you can see visually that it's less common that either the T17 high, denoted by high expression of the T17 signature genes, or the low profile, where there is low expression of all these signature genes. We then did a sensitivity analysis using, instead of the first approach called K-means clustering, 5 alternative clustering approaches, and we yielded the same results. We came to the same conclusions. T2 high was less common. Now, when you look at the characteristics, if you look at the two largest cohorts, it is true that the T2 high profile had the highest IgE, the highest eosinophil count of all the different profiles. But atopy itself, being sensitized to at least one allergen, was a very poor differentiator across endotypes. While most of the kids with T2 high asthma were sensitized, up to 50% of those with either T17 or low were atopic. So atopic asthma is not the same as T2 high asthma. Then we went on to look at a combination of biomarkers that we use in clinical practice, namely total IgE, eosinophils, and FeNO. And we found that if you combine these three, albeit using higher thresholds than those commonly used in practice. It was 417 for total IgE, 210 for EOS, and a FeNO of about 33. You get an accuracy of about 88%, for T2 high. We also did a differential expression analysis, comparing each, the T2 and the T17 to the low-low. We identified some genes that were reassuring that had been previously implicated and some novel genes. And we did a pathway analysis, and here you see some of the things that people had previously identified in terms of pathways for glycoprotein metabolism, and then for a T17 immune responses to viruses. In summary for this component of the talk, we showed that you can, in kids, use nasal transcriptomic profiles to identify 3 distinct endotypes. That contrary to common assumptions, in these high-risk populations comprising predominantly Puerto Ricans and African Americans, the 2 most heavily affected groups in the US, T2 high asthma was the least common of the 3 profiles. What made this study different from others that you'll see in the literature is that we required that prior to nasal sampling, the participants had not used any systemic corticosteroids for at least 4 weeks, which would be a major confounder. Moreover, 98% of the participants in the 3 cohorts had not received any nasal steroids either. They were also not smokers. I mentioned that Spira had shown that smoking can break this correlation. So, it is what it is. Now, what we said then was we need to do integrative omics analysis, which we are conducting now. We also need to look at endotype-specific risk factors. And our ultimate goal is to be able to do clinical trials where you don't include all asthmatics, but you only target specific endotypes. If you recall the history of the biologics, when they did the initial trials, all asthmatics were included and the results were negative. It was only until they started to use biomarkers that you saw positive response from biologics. So we think we can do the same. Now, I told you about kids. What about adults? This is very early, and we're still working on this paper. I just got some new results yesterday, but this is a heat map of Latino participants in adults in the study of Latinos. These are predominantly Puerto Rican adults in the South Bronx and Chicago with some Dominicans. Here, we use not only T2 and T17 signature genes, but also following on the work by John Fahey, signature genes for T1 immunity. And what we're finding, again, is T2 high is the least common. That's the left column. It's much less common than the other profiles. You do have your T17 high, you have your T1 high, but then there is this very intriguing overlap, endotype of T1 and T17. And you still have the low-low, right? My interpretation of the T117 is in the paper by Fahey, he did not use T17 markers, and he found corticosteroid resistance. In retrospect, I think that was a mixture of the T1 and T17. On the other hand, we didn't include T1 signature genes, and perhaps that's why we saw such a strong viral immune responses, when we did the analysis. So more on this to come. We're trying to replicate this in a second cohort. This is a study of adults of African descent. It's called Kappa. So these are adults from Nigeria, Brazil, Barbados, and the US. And here you have the heat map. And you again see that T2 high is the least common, in these individuals of Black descent. Much more work to be done. We have to do a lot of sensitivity analysis and stuff, but this is very intriguing. So let me talk a little bit about endotype-specific risk factors and talk about obesity. So there are parallel epidemics of obesity and asthma in this country and many industrialized nations. The association between obesity and asthma has now been known for about 2 decades. This is a paper from when I was a fellow, and this analysis of thousands of patients in Anhui, a rural province of China. And what we see here is an analysis looking at asthma in 2 different ways: physician diagnosed and airway responsiveness to methacholine with symptoms, which is independent of a physician's diagnosis. When you look at gender-specific analysis, looks like the woman, when you look at physician-diagnosed asthma, has a stronger association. But when you link physician-diagnosed asthma, you also see this association in men. So this has been replicated, as you all know, many times over. in cross-sectional and longitudinal analysis, including our own. So this is an analysis of our two of our studies in Puerto Rico. At the first visit, the kids were 6 to 14. Then we saw them again when they were 9 to 20. And what we saw is that the kids who became overweight or obese at the second visit, which was about 5 years after the first one, had a much higher risk of severe asthma exacerbations. We also showed that when you look at lung function growth, FEV1, FBC had lower growth in the kids who became or were persistently overweight or obese for 5 years. We just published this paper with some colleagues in Europe. It's on can we prevent asthma? And we estimated that if you prevented obesity in kids, you prevent about 5% of cases of asthma, and in adults, the proportion will be about 10%. So this is a very important risk factor. Why do your patients with obesity and asthma are so difficult to treat? So this is a paper from 14 years ago with Eric Forno. This was a clinical trial in children called CAMP. And what you're seeing here is a comparison of inhaled budesonide versus nedocromil and placebo. On the left side, you see the kids of normal weight. And in those kids, the ones treated with inhaled steroids always had a higher FEV1 FBC. You didn't see that for the overweight obese kids. Even more striking, inhaled steroids led to a 44% reduction in ED visits or hospitalizations over 4 years in the kids of normal weight. But the p-value was 0.97. It was almost identical for the kids who were overweight or obese. There was really no effect of inhaled steroids, suggesting corticosteroid resistance. This got more interesting because Dale Lumezzo at Harvard then did a mouse model of obese asthma that was published in Nature Medicine. We published an editorial on this with Jay Coles. And what this showed was that in this mouse model of obese experimental asthma, this is mediated by inflammasome and Th17 pathways, not Th2 pathways. So I wanted to look at this in humans. And we had data, publicly available data in adolescents in a nationwide study called NHANES. On the left side, you have the relationship between BMI and asthma by quartiles in kids who had low FeNO, which, as imperfect as this may be, is a marker of airway eosinophilia. And in those kids, you see a linear trend. As the BMI increased, the odds of asthma increased. You do not see that for the kids with a high FeNO, where the relationship is pretty flat. Again, suggesting perhaps non-T2 mediated mechanisms. After that, we'll look at another potential mechanism, airway desynapsis. So desynapsis refers to an incongruence in lung growth whereby lung volumes grow faster than airway caliber. So these patients have low FEV1 FBC despite a normal FEV1 and FBC. We had data in over 4,000 kids from 6 different cohorts. We did cross-sectional and longitudinal analysis. And what we found is where you look at BMI or obesity, there is a relationship with airway desynapsis. And airway desynapsis is in turn associated with severe exacerbations, ED visits or hospitalizations, or use of systemic steroids. Again, suggesting non-T2 mediated mechanisms. This is a paper that really caught my attention. To me, this is really a landmark paper. It's a paper in Nature from a group at UCSF. This is not an asthma model. This is a model of atopic dermatitis, okay? So what they show in this mouse model, you have the lean mice, and when you look at their immune phenotype is, as you expect, Th2 predominant. They treated the mice with biologics, they respond, their atopic dermatitis got better. Now, they fattened the mice, and their phenotype changes to Th17 predominant. And once they gave them biologics, their eczema got worse. Not only did it not improve, it got worse. Once they, again, made the mice of normal weight, everything reversed. So it's really fascinating. So then they did single-cell RNA-seq genome-wide binding analysis, and they revealed decreased activity of PPAR gamma and Th2 cells from obese mice. And they show that if you treat the obese mice with a small molecule PPAR gamma agonist, you limited the T17 pathology and they became again responsive to biologics. So not asthma, but boy, is very interesting. So this is another analysis we published last year. We did not have transcriptomic profiles in ENHANCE, this public data set, but using eosinophils and FeNO, we try to divide the kids very coarsely into low and high, and we again find that overweight and obesity are associated with T2 low asthma. But now we have the transcriptomic profiles, right? So this is a paper that was just published in the Blue Journal. And what we did is we took our Puerto Rico cohort. We have data in control. So this is a multinomial regression analysis where you're seeing here is a comparison of each asthma endotype to controls. And you can see that the association between overweight, obesity, BMI, and percent body fat is more strongly and more significantly associated with T17 high and T2 low, T17 low asthma than with T2 high asthma. So I would say that carrying evidence from epidemiologic studies and mouse models suggests that overweight obesity can lead to asthma through non-T2 mediated mechanisms, including T17 pathways. I think the data are becoming stronger, and also probably non-immune mediated mechanisms, including abnormal lung development and structure like airway synapses. But the question that I have now is, could somebody that you're treating with T2 high asthma become obese and develop T17 high, or at least an overlap between T2 and T17, and that's why they are so difficult to treat? Could you, going further, reverse obesity and change their asthma type, right? Fascinating. So in this field, what's really needed is longitudinal studies and clinical trials. So in terms of future directions, in pediatrics, the million-dollar question is, most babies who wheeze before age 3 years don't have true asthma. They have something called transient wheeze. Can you do one of these tests and tell the parents, don't worry, your kid is going to be okay. You'll struggle a little bit, but he's not going to have asthma, right? Wouldn't that be great? And then at all ages, can we develop predictors of treatment response? Can we do what is much needed, which is clinical trials targeting specific endotypes other than T2 high? Right now, we have several ongoing studies. We are now conducting longitudinal studies of nasal omics and asthma exacerbation and lung function decline in Puerto Ricans, Dominicans, and African Americans with funding from NIH. I'm also leading the respiratory component of a large U24 grant called Mosaic, which includes 11,500 individuals of Hawaiian, Pacific Islander, and Asian descent that just started. And I also have a local study of nasal transcriptomic and exacerbation in adolescents and young adults in Pittsburgh. Now, there are a lot of early career faculty, so let me tell you a bit about my journey. So these are words by Tennessee Williams. We are saved only by love, the love for each other and the love that we pour into the art and science that we feel compelled to share. I'm originally from Barranquilla, Colombia. It's the largest city on the Caribbean coast of Colombia and home to the second largest carnival in Latin America, second only to Rio de Janeiro. The Caribbean coast is also the birthplace of Gabriel Garcia Marquez, pictured here, Nobel Prize for Literature in 1982. There you have the yellow butterflies in 100 Years of Solitude, which for you young parents who went to Encanto were also shown in that Disney movie, the yellow butterflies. So, but I didn't go to medical school in Barranquilla, but in Bogota is the medical school of Dr. Gomez, Universidad Javeriana, which was founded in 1623. So it preceded the foundation of Harvard by 13 years and that of Yale. I'm very sorry to disappoint you. Yes. After my Lincoln internship, I had the good fortune of working at Beth Israel, which is part of Mount Sinai in New York, and met the late Mark Rosen, and then did my fellowship in pulmonary critical care at Brown, where I worked with Sharon Rounds and Nick Hill. I sent again 400 letters of application to try to find a sponsor for a green card and got one interview. And I ended up serving 2 years at the Veterans Administration Medical Center in Erie, Pennsylvania, which is 2 hours north of Pittsburgh. And the reason why Hillary Clinton didn't become president. That's where she lost Pennsylvania, by the way. So after the 2 years of government service, I got my green card, and I finally could do research. I became training grant eligible. So I went to the Channing Lab of Brigham and Women's Hospital, where I worked with Ed Silverman of Human Genetics. He was starting his career in COPD genetics, and Diane Gold on early life risk factors for asthma. That's why I started these parallel sort of studies. And then everybody needs a mentor. And mine, a wonderful mentor I've had is Skip Garcia. You know, he's been a wonderful, generous role mentor, very inspirational, somebody who's always cared about health equity. You know, I'm very grateful to him. But I'm really proudest of the people I've trained. Picture here, you have 16 recipients of K grants, 11 recipients of R01 grants, 4 division chiefs, 4 elected members of the American Society for Clinical Investigation, and all great people. You're only as good as the people you work with. You all know that. I've been blessed with collaborators in the US and worldwide and funding from NHLBI. And over the last 15 years, I've been very fortunate to lead a wonderful group of people at UPMC Children's in Pittsburgh. A really career growth time for me was serving in the executive committee of the American Thoracic Society for 5 years. And I was not only the first Latino president, but I also hold the unwanted distinction of being the only ATS president who never had an in-person meeting, because I was the COVID-19 president, okay? So when you're faced with these circumstances, you can go like Hagar the Horrible, you know, his ship sank, and you say, why me? And then there will be a voice from the skies, I have news for you, which will tell you, why not, right? So when bad things happen to you, all you can do is smile and trust the people around you, do your best, and usually things work out. And that attitude came from my home. You know, that picture on the right side was a physician, and I still see that as Don Quixote, you know, the fictional character in a white coat, battling the giant windmills of social injustice and sickness. And then my mother was the toughest human being I've ever met. Mom lost her father at age 6, would go on to lose a brother at age 20, lost 2 kids, my sister and my brother, pictured here, but her faith in humankind never wavered. Every call I had with her ended with, may God bless you so you can serve humankind. Now, you cannot choose your parents. That's a random cosmic event. You're lucky, you're not. But you can choose the person you're going to spend your life with. In Latin America, you're told that you have to pray every night to your guardian angel. And I married mine. I did much better than praying. So with Lily, we raised 2 wonderful daughters. We've been to 86 countries and counting. And I hope to continue to do so. Last one was New Zealand. Now, we're going through one of the darkest periods in the history of this great nation, one in which education, healthcare, science, public health, and human rights are under relentless attack. It's very easy for each one of us to fall into despair. But while we're drinking from this bitter cup, I know that together these too shall pass. We shall overcome. And so for you early career faculty, my advice is simple. Find a cause or causes you're passionate about. Pursue them with unparalleled passion. Surround yourself with people who love you and love them back. Be a lifelong learner and teach and support the next generation. And if you do all this, you can be at peace, knowing that when the candle of your life is extinguished, the causes you fought so hard for will shine ever brighter in an eternal flame. Thank you. I'll take any questions.
Thank you so much for a wonderful talk about science, but also amazing advice. You know, I think we shared the same country, right? And I think we were talking briefly about it. And when we were growing up, there was a lot of chaos, as you can imagine, from our government fight with the cartels, and it was a really challenging time. But I think if you're able to be together, right, and kind of like trust, like you said, trust each other, there's a lot of strength as a team, and we definitely should advance these causes because like you pointed out, these are the patients that we see in our clinic all the time. Like, our most challenging patients with asthma, severe asthma, most of them are Puerto Rican. Most of them have, to get through like multiple biologics to finally be able to live, basically. Like many of them have significant limitations for many, many years. And obviously, like what you're studying has an important effect on what we treat. So we appreciate your leadership on that.
Thank you.
All right. So any questions?
Sure.
Thank you, Dr. Celedón.
Hi.
I loved your talk. If I knew the last few minutes were going to be what they were, I would have invited the entire residency to come. We have a rising chief resident from Colombia and many residents each year who we recruit from your country, and they're superb. Going back to the earlier part of your talk, you had an interesting slide comparing Latino patients from different countries. And I noticed that there was a pretty significant difference between Puerto Rico, but also the Dominican Republic and Cuba. And I'm thinking, what signal are we seeing here in the sense that they're from a fairly similar geography? Ethnicity is somewhat similar, but very significant differences in rates of asthma. And I'm wondering what you understand from that.
I tell you, it's fascinating. So there is an old study by Ledogar. This is New York. He studied families living in the same projects in New York. So here you have Dominicans and Puerto Ricans living not only in the same neighborhood, in the same buildings. And the prevalence of asthma was higher in the Puerto Ricans. And I don't know, diet is different. Puerto Rico was the first place outside of the continental US to have a McDonald's. Oh, yeah. And they are far more Americanized, of course, than Dominicans, right? Exactly what specific, risk factors differ, I don't know with confidence, but they are different. Yeah.
Thank you so much. That was such an amazing talk. I did my residency at Sinai as well, in med peds. So I had a lot of these patients who I would have throughout their continuity. So I had two questions for you. The first one is, do we know the specific risk factor that can lead to a certain endotype? So for example, like if someone lives in a gentrified community who lost their home and then had to migrate for that reason, or someone who's just exposed to smoke exposure, does that give you a different endotype and then can help target treatment? And then the second question I had is more so like, how are we protecting your research, which is truly amazing, from being misinterpreted from individuals who may read it and say, oh, well, this group has a higher rate of asthma, but that's not truly what you're saying?
Two great questions. So the first one is, I show you data on obesity, right, as an example, because it's probably the most mature. We just got a paper accepted today where we look at secondhand smoke, and this is an imperfect measure. We didn't have urinary cotinine, so it's questionnaire data. But what we're finding is that actually secondhand smoke is associated with the T2 low, T17 low, the low endotype, right? Again, suggesting, which makes sense when you know what secondhand smoke does in kids with lung development and a structure, right? It may be a completely different pathway. They still have the symptoms of asthma. So I think you're going to see more and more, we thank God have a lot of environmental data on this cohort so we can look at endotype specific. The second question I was sharing with people, we have a summer research program for underrepresented, people in medicine, right? And we were not getting the notice of award last year. It took a while. So after 3 months, I emailed the program officer. It was a very nice person. And in essence, what I had to do was to delete all this language that MAGA, it has these AI algorithms for, and I got funded. And I just went through the same thing. I got red flag. I had another call with a program officer, and I will change. One thing about immigrants is we know how to survive. So I'll do whatever it takes, to get this work going. So we'll get it done.
Okay. Well, Juan, it was a fantastic talk as our conversation went. I was just this thing that you showed about the Th2 and Th17 about treating, like targeting Th2 in a Th17 model, worsening the inflammation. What's the mechanism they give? One, I mean, I'll go through the paper, but I just wanted to know what you think from a human side of you. And then, have you seen any signal like this? Look, in the patients who have higher BMI treated? I'm sure you have those. We have those. Treated with MEPO or DUPI, did they get worse?
So anecdotally, the second part of the question, I would say that everybody in this room who has seen enough patients has had this experience, right? Where you may have this person who had atopic asthma since childhood, and then they become obese or they gain weight, and boy, are they now hard to treat. And we don't have the data, but I'm very suspicious, right? Given the mouse model that they switched to Th17. I don't know that they gave a great explanation, for why it is able. I mean, a very simplistic explanation is you block now T2 and T17 goes, wild, right? Because they are reciprocally regulated, but yeah.
I don't know if I'm on the mic. Yeah. Okay. That was an amazing talk. I think my question is just sort of towards your journey in the tail end of the talk. It struck me that picture of the man who's, where you describe the struggle of the current times, he's isolated. He's one person. And I think an isolated experience can often feel more overwhelming than a shared one. And as you described all this amazing work that you're doing, looking at disparities in asthma, I'm curious what your take is on how ATS in particular or other spaces can provide community for discussions and resources to motivate early career investigators who are trying to do disparities research in this climate.
What a great point. I think that for us who have had ATS as their home, right, it just creates a community, of people who are in general supportive, right? And you can share all these experiences with. I also think that ATS was a pioneer, in health equity, in all the initiatives. Now all the other societies copied us, which is fine. It's great, better for everybody. But we were the first people to sort of really go all out, on this. And it's something I'm very proud of. But yeah, you're not alone. That's the point, right? We're not alone.
We have a couple of messages here on the chat. Like first, Dr. Aiken, one of our faculty, such remarkable work and your closing wisdom is so inspirational. Thank you for sharing your life with us. And the second comment from Dr. Mathe, he has a question. Is the favorable impact of GLP-1 drugs on asthma due solely to weight loss, or do you conclude that there are other mechanisms, and what are they?
Wonderful question. So thanks to Dr. Ian. And then for Dr. Mathe, there is early evidence that GLP-1 agonists may have favorable effects. And this is very early, and industry is very interested in this, that GLP-1s may also have anti-inflammatory properties. The exact mechanisms, I don't know. But, there are some observational studies with metformin, GLP-1, right? We do know that bariatric surgery in adult patients with obese asthma in general, the trials are small, improves their asthma, right? It's been shown several times. So I can see how that would work. So, Jeff?
I'll just started the first portion of your talk suggesting that kind of pure TH2 from a transcriptomic standpoint is less common, actually, than maybe a mixed or a TH1, TH17. But the biomarker data suggested that, at least from an eosinophil standpoint, that TH2 high is actually, common, which is by classic biomarker, although atopy was kind of low. So, what do you think's, going on there? Like, do you believe that, because we're classically taught that TH2 high disease is 80 to 85% of patients by, various classic biomarkers. So do you believe actually that, it pulls through in a, what's the ultimate kind of conclusion here? Is it that that TH2 high disease is not that common, or that?
Well, I would say, right now we have, I don't know how many cohorts, 6 cohorts, with Puerto Ricans and African Americans that show a T2 high, at least for transcriptomics, right? It's not as common. And isn't that curious that they are the most heavily affected, right? And if you look at a lot of these studies, they are lily white, I'm sorry. They don't include white patients, right? So I don't know how much of that would be ethnicity. But the other thing, to be fair, is that I don't think these are static endotypes. You and I were discussing this earlier. We don't know yet. I'll be the first one to say this. What happens over time? How stable are these things, right? If your T2 high patient has a rhinovirus infection, he has an exacerbation, if we endotype that patient at that time, he could be T1. I believe that, right? And the obese patient story, I think, is going to pan out. That you have somebody who's obese that by some method, where it's surgery or GLP-1s or whatever you do, you type them before and after. I think that's going to change. It's also possible that depending on the risk factors that are specific to your community, you may have one endotype predominate over other. That remains to be seen. So I'm not saying T2 high doesn't exist. I'm just saying we've oversimplified the story. I think that's the take. It's just not all T2 high. Yeah. Yes.
Thank you so much. I think I have the last question. So I really appreciate your talk. Very, very informative and very inspirational. So I really appreciate it. I wanted to ask, and I'm sorry I missed the first few minutes of the talk because I came late. So if you addressed this, I apologize. I was curious about why, and you mentioned a little bit of why Puerto Ricans have such a high prevalence of asthma, especially compared to other Latinos and even other groups that experience similar issues with social determinants of health and obesity and everything like that. And I've heard one theory be the air quality coming from the desert air of sub-Saharan Africa and coming to the Caribbean, and especially when we're talking about the other groups of Dominicans and Cubans as well. But I have also heard that a lot of Puerto Ricans, and I've also seen this in my clinic, that they feel that they have asthma in Puerto Rico, but then they move to New York or they move to Connecticut and their asthma is so much worse. Some people's asthma gets worse, some people's asthma gets better. And so where do you see some of those theories play in? Are any of them real, or are we really just talking about all of the social determinants that we know about in terms of socioeconomic, obesity, discrimination, those types of things?
I mean, unfortunately, right, Puerto Ricans are really a high-risk population. So let me start there, right? So prematurity is a very strong risk factor for childhood asthma. Puerto Rico is the U.S. state or territory with the most premature birth. Puerto Rican women smoke the heaviest of women in all ethnic groups. They have higher levels of air pollution in San Juan. The levels of mold are high too. And mold is not good if you have asthma. It doesn't matter what the endotype is, a very potent irritant. The rates of obesity are very high, because of their poor diet. Tomorrow, I will talk about violence. Unfortunately, they are exposed to violence very often in Puerto Rico and in the mainland. However, going back to your point about New York, we did a study of that years ago. So in Mexicans, what happens is with every generation in the US, the risk of asthma doubles. the grandchild of a Mexican immigrant will have 4-fold higher odds of asthma than grandpa. Okay, it's been shown by Fernando Holloway. There are at least 2 or 3 papers on this. We did a study comparing kids in the Bronx of Puerto Rican descent to Puerto Rican kids in Puerto Rico. They both had very high indices, of hospitalization, CD visits, but they were higher in Puerto Rico, which is the opposite of what you see with Mexicans, right? So it was a big problem at both sides. Sometimes, I was talking about this with somebody earlier, in asthmatics, you have this thing where your patient moves to Arizona and they call it and say, "Doc, my asthma is so much better." And they have like a honeymoon because the allergens that they had here, if they got T2 high, are not there in Arizona. But the data shows that after 5 years, the honeymoon is over and they become sensitized to alternarian. So, they become sensitive, whatever it is in their environment, right? So, yeah.
Thank you so much.
Thank you.